Chapter 10, Treatment of Cognitive Disorders. This chapter presents a discussion of the various forms and causes of dementia and how best to treat them and reduce the negative aspects caused by these conditions. The advantages and disadvantages of various medications for cognitive decline are explored and discussed. There are many types of cognitive disorders. However, this chapter focuses on delirium and dementia. And out of the two, this chapter mainly focuses on dementia. But if we were to take a look at delirium, delirium is an acute confusion state. Symptoms may include changes in alertness, changes in feelings of the sensation and perception, changes in levels of consciousness or awareness, changes in movement, sleep patterns, drowsiness, and amongst other symptoms. If a client is showing symptoms of delirium, it is very important to get them to a hospital as soon as possible so a physician can see them. The second disorder we will discuss is dementia. Dementia is becoming more of an issue for our aging population. Alzheimer's disease, which sometimes is called AD, is the most common type of dementia that affects individuals. When we look at dementia, the central feature is memory disturbance. There are three common forms of dementia: Alzheimer's disease, dementia with Lewy bodies, and vascular dementia. Alzheimer's, which is the most common form of dementia, consists of memory problems, aphasia, which has to do with language and speech, apraxia, which deals with our motor movement, and agnosia, which can affect their ability to recognize objects, people, and events that they would normally be able to remember. With Lewy bodies, DLB is the second most common. Key features are memory dysfunction with visual hallucinations, Parkinsonism, and or fluctuation levels of alertness. Vascular dementia, which commonly leads to DLB, as well as HIV associated with dementia. With Alzheimer's disease, or AD, it's a gradual onset. It is a progressive decline in cognition and motor functioning. However, the motor functioning, that decline occurs later. There are various identifiable characteristics that individuals have with Alzheimer's disease. When looking in the brain with a client with Alzheimer's disease, they have found amyloid plaques, which is one of the hallmarks of Alzheimer's disease. There's an accumulation of amyloid plaques between the neurons in the brain. Amyloid is a general protein fragment that the body produces normally. In a healthy brain, these protein fragments are broken down and eliminated. However, in a client who has Alzheimer's disease, the fragments accumulate to form hard, insoluble plaques. Neurofibrillary tangles are insoluble twisted fibers that are found inside the brain cells. These tangles consist primarily of proteins of a structure called a microtubule. The microtubule helps transport nutrients and other important substances from one part of the nerve cell to another. However, in a client who has Alzheimer's, there's an abnormality and the microtubule structure actually collapses. With the synaptic loss, we're simply looking at the fact that the number of synapses have decreased and the synaptic contact has also declined. A loss in acetylcholine. Neurotransmission pathways have also been researched with Alzheimer's disease. Researchers indicate that several neurotransmission pathways may be involved, including cholinergic, glutamatergic, serotonergic, and dopaminergic. Currently, the loss of cholinergic neurons appear to be the most important abnormality. As mentioned earlier with characteristics of Alzheimer's disease, and we talked about amyloid plaques. What has been found is that the amyloid plaques affects the brain except for sensory, so we're looking at our five senses, as well as it does not affect the motor region. Chronic neural inflammation initiated by beta amyloid has also been looked at in clients with Alzheimer's disease. There's also various theories of faulty genes. Glutamate is thought to play a prominent role in the early stages of individuals with Alzheimer's disease. Looking at medical and behavior evaluation, an inventory of prescribed and over-the-counter medication that the client is currently taking is very important. It is also important to obtain past psychiatric history from the client or also family members with major mental illnesses that might develop into dementia. When we look at delirium, it is reversible and is associated with pharmacotherapy. So as mentioned earlier in the PowerPoint, if a client is showing symptoms of delirium, it's very important to get them to the hospital as soon as possible so they can see their physician or just a physician period. But there are medications that can reverse these symptoms. Another theory behind it is a B12 deficiency. Vitamin B12 deficiencies as well as hypothyroidism may present as reversible cause of cognitive disorders if detected in the earlier stages. Other medical conditions such as tumors or hydrocephalus. Evaluate cognitive and behavior factors that may also cause the dysfunction. There are a few medications to treat Alzheimer's disease. The medication modestly improves cognition functioning. However, it does not significantly improve it. The medication also assists clients with being able to mentally do their daily activities as well as behavior functioning, so it stabilizes their cognition. Cholinesterase inhibitors, which pretty much so are medications that stop acetylcholine from breaking down, slows the clinical deterioration of Alzheimer's disease, but it doesn't cure it. And a negative side effect is liver toxicity. Second generation cholinesterase inhibitors that are equally as effective without the hepatic toxicity and has shown positive effects on mild to moderate AD. Now the side effects may include gastrointestinal symptoms such as nausea, vomiting, diarrhea, amongst other side effects. Cholinesterase and butyrylcholinesterase inhibitors regulate the brain's acetylcholine levels. This may be effective with behavior problems that are prominent with DLB and aggressive symptoms such as hallucinations. N-methyl D-aspartate or NMDA receptor agonists reduce the production of excessive glutamate, which may overstimulate the NMDA receptors. Too much overstimulation may lead to neural death. Other approaches. Vitamin E and other antioxidants have been used to slow the progression of aging and dementia. Ginkgo biloba has been believed to improve cognition. Postmenopausal women suggest that estrogen replacement therapy decreases the risk of Alzheimer's disorder. However, we must keep in mind that with the increase in estrogen, this also brings a risk for heart disease and breast cancer. Non-steroidal anti-inflammatory drugs might decrease the risk of AD in some clients. The decreased inflammation caused by the plaques containing the beta amyloid, the neurons have less damage and cell death. Lipid lowering agents that lower cholesterol may be useful in preventing AD. Other significant issues to consider. Behavior issues such as physical agitation, verbal aggression, physical agitation, depression, psychosis, we need to take into consideration when we have clients with dementia or AD. Is to define some target symptoms, which will dictate the treatment protocol. So, for example, an atypical antipsychotic agent will be considered as a starting point for a client who's presenting agitation, aggressive, or psychotic symptoms. So we may look at something such as risperidol or another atypical antipsychotic. Or if a client is showing more of a depression, we may look at a mood stabilizer. Overall, as clinicians, it is very important to look at the target symptoms of all of our clients in order to dictate and have an effective treatment protocol.